So here I'm going to just show you. So we shared what is the system, and then we do a lot of monitoring. I'll show you all the data what we do when we do the thing. I'll take a little more time. What to say? So now we can do the monitoring just by looking at the number of patients or the clinical procedures, the outcome and the complications. Like we also regularly generate reports why we don't operate the patient, why we postpone the patient, why we spend so much of money to bring a patient to the hospital, not operate, send them back to the campsite. So we have data to show all that. The list for unoperated cases. For every month we take it, and we have a process to review that. Every monthly meeting it happens. So like one of the common causes are diabetic, uncontrolled diabetic. The reason for not operating on the same day may be uncontrolled diabetes or a hypertension. So we have some idea about that. So now one of the counseling, the important point we put is to bring all the medications, and also if they got a multiple problems, we ask them to come with an attendant, saying that even if you come after a few days, we'll do the surgery free of cost. You don't have to worry about that. But we want to share that responsibility with the family. So that's one thing we do. And similarly, we also look at the A-scan accuracy, whether the A-scan is within one, the post-operative spherical equivalent is within one diopter. That's what also we monitor. We also monitor resurgeries. We'll be happy if it is around about less than 1.5%. And then Dr. Haripriya also showed you the learning curve, because I'm not going into that. And then regarding the monitoring of the visual outcome, I just share with you a software tool we have developed. Now, whatever Dr. Haripriya showed, now we can do it on a web-based platform. If some of you are interested to adopt this, we are willing to share this kind of a tool, where you can put all the data. You'll be able to get a report for your own hospital, and also if you want to compare with others, if you load all the data, we may be able to do a benchmarking also with the other people in the network. So here is the demo. It's all live data, what you are going to see now. Ganesh? You can say it. So we have for all our hospitals now, about 8 hospitals, we have installed this system, where each hospital has got a unique username, password, and then we are also making it shortly available for each doctor. Each doctor will have a login name and a password. So here, this is like when you want to do a data entry. Some individual doctor wants to adopt this. We have also given a case sheet wherein they can enter all the data for the patient detail, IOL detail, intraoperative complication, postoperative complication, resurgery, the preoperative vision, discharge vision, follow-up, complication, infection. All this data is also, for individual patient, they will also be able to put the information. So for us, they have a way to collect the data and upload it. And this is a summary data. For example, I'm just taking it for all the hospitals. They can look for paying patients, free camp patients separately. And I also can look at the data for each individual group, whether it's fellows, medical officers, doctors, and for surgery type also, whether it is a ECC, small incision, phaco, lens removal, all that we'll be able to see it. So we have the data now up to March. The April, still the patients are coming for follow-up. That is not current. So you can see the March 2012 data here. So during that period, that month we have done about 8,582 surgeries. So about 25% had a phaco, 72% had a small incision, about 1.49%, about 128 patients had an ECC. The ECC is more for a training period. Usually when the doctors start, the first 3-4 months, they may do this procedure. After that, we train them in small incision. So we also have data on anesthesia. What is the type of anesthesia? We had a topical in 15% of the patients. Most of them are maybe phaco. Whether we also capture any globe perforation. So this month there was nil. Probably we may have about 2 or 3 cases in a year. And then this is an intraoperative complication. How many DM detachments? As you can see, there were 139 complications were there across paying, free, and all that. So we have which accounts for about 101.62%. And then this is a post-operative complication. The common one is a corneal edema, which is like about 1.29%. So we also capture other insignificant complications just to see. So which feel may not affect the thing. Then we had a resurgery in 101 patients, which is like 1 point. So this is immediate at the post-op. We used to do a pinhole for the patient's vision. So 61% had 6/9 or better with the pinhole at the time of discharge. And then follow-up, we give follow-up for the patients in the base hospital or in the campsite or at the vision center, or some of the patients who have been referred, or from a very far off patient, we give them a referral to see the local doctors. So that is also there. So of the patients who are asked to come to the vision center, only 19% went, because we tried to get the data also from the vision center. So that is we were able to get it for about 20% of the patients. And then who are followed at the base hospital, about 82% during the month of March of all the patients, paying, free, camp, we have about 82%. Who came to the campsite is about 82%. Always we have a belief. When you operate in a camp, the follow-up is very poor. You can see here, the follow-up is as good as the patients who are coming to the base hospitals. And here we are not able to get the data from when we refer a patient to other doctors. We tried giving them a slip which they can get it filled by the doctor and send it back to us. It hasn't really worked. We tried our best. So this is the uncorrected visual acuity, and this is the best corrected visual acuity. So about the best corrected is about 87%, sees better than 6/9, about another close to about 9%. So this together about 96% of the patients got a best corrected visual acuity of 6/18 or better. So then we capture the follow-up complications. About 0.02% were a wound complication. Then this is the spherical equivalent to see the accuracy of your A scan. This is about 92%. We're within our benchmark. So this is what we also expect with a contact, this one. So if you can see, we had about 8 infections, which amounts to about 0.09%. Less than 1 per 1,000 is our thing. And then of that, majority of that is culture negative cases, which may be due to some toxic reaction. About 0.03% were the infective cases. So we'll be able to, but there's a lot more we can see, a lot more details we'll be able to see in this. For example, if I want to see as with the surgeon also, it's possible. So any doctor, they want to see their data, they can see it. Okay, so anybody. So for example, where is my finger? Yes. So here you can see all the data about paying, free, and all that. So I don't do a large volume. So I've done about 130 cases in that month. So about 2 free patients, the rest are all the paying patients. So that data is also available. I can see. So now we'll be giving probably a password for each one. So they'll be able to see it. I had about 0.8% complication rate. So resuturing, I had a 1.5%. 2 patients had a resurgery. So 96% of them came for follow-up, 89%. So this is the about 90 to 80% had 6/9 or 6/6. So all this data is available here. So any doctor can see it. Okay, we can also, if a particular thing you want to see, I want to see all my post-operative complications, what happened to them, you'll be able to get those numbers, names, which we can see it also. So this is, and we also have, look, huh? So we also can get a benchmarking data. So here you see this is this hospital data. This is the overall data across all our 8 hospitals. And we also got some benchmarks which we say that probably the best thing what the hospitals to aim for. So this again will be also be possible with all the hospitals. Okay. So there are some hospitals across the system, across 8 hospitals, the infection rate is like 0.05. It's like 5 per 10,000. So this is the number of hospitals which are enrolled and the data is available. If let's say another 15, 20 hospitals would like to join the system, all of them can put, and then we can have a bigger database to compare, benchmark, do all that. All that possibility is there. So I just close with that. I'll just go with the other presentation. This is, we also do what is called a parameter, an annual review meeting, where we look at our data very comprehensively for all the departments. So earlier we have a monitoring system where our founders, the senior doctors used to visit the hospital, used to have a formal interaction, try to find out what the problems are, and then give the feedback based on the data they see. There was no structured program. With the current transition process, with the number of more hospitals we are opening up, we have developed a structured process for capturing all this information and also for analyzing it, so that we know in the long run all our hospitals are running efficiently and with good quality. So we have looked at the 5 dimensions. One is quality of the documentation. How are the case sheets, whether the data we want is all complete there. And then the service volume, the volume of patients, how does it compare with the previous years. The quality of the services, which means an acceptance, especially the counseling and all that. Then the academic training activities and the human resource issues. So we looked at all these clinical departments. So there are roughly about 23 departments. We look at refraction separately, outpatient, operation theatre, specialty clinic, and also non-clinical departments, medical record, even catering, library, stores, IT department, everything is also monitored. So just to give you an idea about the indicators, for example, in the quality of documentation, we look at the documentation findings, details of the procedure notes. Mr. Junaid was saying about that, how do they document all that? The details of staff delivering the care and the service volume, the clinical quality, whatever we saw recently, and the service quality, mainly the acceptance. Academics is number of the physicians, staff trained, classes taken for the postgraduates, CMEs, human resource, how many people turn, the turnover rate, the attrition you are asking. All the details are also taken here. The process works in this way. So daily, every day, the data is collected from the database, and it's also entered into that parameter. We have the thing where they can enter it either manually or into the computer. Every month there is a departmental meeting. Within the department, the chief of the department will look at all this data. They review within the department. And then once in 6 months, the chief medical officer, they have a structured process for 3 days where they look at all this data. Then annual review is done by a doctors, nurses from another hospital. Like a group of doctors from here, 2 or 3 hospitals will go to Pondicherry. A group from Pondicherry, Salem, or maybe Madurai, Coimbatore will come to Madurai. So they will look at all the data. Probably it's a 4.5 days process. It's a very long, lengthy process. Each department, the review takes at least about 2.5 hours to 3 hours. And then once everything is done, all the cornea clinics, 5, 6 hospitals, they come together, look at what has happened, where is their lacuna in each of these different hospitals, and they come up with what is kind of a best practice or a benchmarking the thing. So overall, it takes about 1.5 to about 2 months process will be able to do it. I'll just show you briefly For example, this is the OT, the parameter for Madurai. So it's quite extensive. So I'll take just to show you one of that thing. So this is talks about the service part of it. This is paying case from where these patients came. So you know that we have vision centers, we have community centers, we have city centers from where the patients came. The total volume of patients, we have done about 29,000 patients last year, which is like 6% more than the previous year. So that is one benchmark we try to see. Whether the volume has gone up, if the volume has not gone up significantly, then we would like to see the reasons. If it has gone down, we would like to see the reasons. So this is from the pre-patients. Then this is from the camp patients. We look at the growth part of it also. And then this is the complication part. This is like the quality. We had about 999 patients who had a PC rent, which is like 1.09%. So for all the 999 patients, we have the data here. Okay. So not only the what name of the patient, what is the type of cataract, pre-operative things, what risk factors they had, who is the doctor, including their post-operative vision, what happened to their visual acuity. So that record is available for all the 999 patients. So for each of these, now we have a link. We can see what all happened to these patients. So we had a complication rate of about like 1.49%. Similarly, for resurgery related to wound leak, redialing, removal of all this information is available. And somebody was asking about infection. So here is the data for about all the 82 cases. Here you can see the difference. So the earlier year we did not include some of the cases where we felt it all could be sterile. So this year we said no, any patient who get an intravitreal antibiotic, will document that. So this comes to about 0.09%. For this 82 patients who had infection, all the very extensively we have documented all the findings, including type of surgery, what investigations were done, how it was managed, who gave it, and also the final outcome, what happened. Whenever the patient comes for follow-up, all the visual acuity documented, each of the visit, everything is documented here. So that is all about the complications and all that, like wrong IOL. So what is the thing? For example, here we have put a wrong IOL in 3 patients. So there are 2 patients who had a +10 for whom they put implanted -10. Okay. So now we have got a different way of writing. If there's a minus power, we got to put a separate sticker also to make sure that the doctors really understand those things. So and also they capture, because of OT, they capture all the specialty surgeries, how many were done, and unit cost also they'll have. What are the equipments they have? This is the manpower details. So 2011, about 12 people have left. So the current they have 122. So probably they had 134 people, 12 people have left the department. And we have, if you go there, we have a reason why they left. All the detailed reason for why they, wherever, whatever it is, no, the actual reasons all will be available there. So supervisors, then the academic, how many people were trained. So that year we have trained about 46 people, short-term trainees, long-term trainees, welfare activities. We have an annual health checkup for all the staff. So whether it was done, and then if you go there, what was done, so all that is also will be available. So meetings, so then it is signed by the head nurse, and then we have a doctor who's in charge of that. They sign off. So similarly, better not to go through this. It will take you to get all the details, everything, to find out about 2.5 to 3 hours time we take. Similarly, if you look at housekeeping, okay, close பண்ணிடுறேன். So we have each department, we have a mission. They must understand what that department mission is, what they have to do to contribute to the larger vision of the organization. Zoom in. Okay. So here again we look at the manpower. This is the most important thing. We look at it first, and then what are all their attendance. Attendance is a major issue in this department. So we try to look at that, and then equipments. We look at all the equipments, how many they have, whether it is all sufficient. Then if you go to the annexure, you will know when it was bought, how much we paid, what are all the maintenance details, all that information you can get it. And then the log book maintained, and they are also responsible for the security, and then what was the cost involved, all the details, how much they paid for each of the things. So we can see if there's a variation between the 2 years, we'll be able to know it, how many complaints they received, how many they resolved it. These are all some of the major complaints. So we have a separate thing about theft. How many theft? There are about 9 theft in that year. So we go, we'll exactly know what was the thing. It's all mostly cell phones, ATM card, cell phone. So all that information we'll be able to get that. So housekeeping, they are also responsible for jaundice, gastroenteritis, anything has been reported in the hospital. So who got it? What was the outcome? The water, culture of the water. Then academics, how many of them they trained, the welfare activities. So like this, about 26, 27 departments all will be seen over a period of time. For the library, for example, I was telling somebody, so we look at the attendance. So if the attendance goes down, the librarians are taken with task. We want the librarians to encourage everybody to come to the library also. So briefly, this is there's a lot more to show and share, but because of constraint of time, I'm not sharing everything with all of you. But it is a challenging process. But it has done a lot to our staff. About 4 or 5 years back, Dr. Nachir, she was a person who really championed it. It's really a difficult process to collect all this data, organize it. Because the thing is, when we sit in the parameter meeting, anybody in the department can be asked to present. Somebody has to present. We'll call anyone to ask them. So every staff in the department will know all the data. So everybody would have rehearsed how to present it also. If 30, 40 staff are there, everybody will know what to talk, what to say, what is the reason. It's not about just telling the data. It's all the reasons behind why this happened, why this complication or why this particular thing. No?